Good day, everyone. I'm Dr. Jerome Rimachas. I would like to welcome you once again in the 7th Philippine Cardiovascular Summit entitled Cardiology for All, from primary to tertiary care and vice versa. I will be your moderator. I hope that you already learned a lot from the previous sessions. So right now, our topic will be about bangungot and other life-threatening arrhythmias. I think this topic is very important and interesting for us specialists and generalists as well. We will be guided by none other than Dr. Giselle Herbacio to guide us through the topic, and we'll start off with a case. So this case is a 54-year-old male who presented with syncope while driving, and this syncope resulted in a vehicular accident. The patient denies chest pain or shortness of breath. He is a known hypertensive and fairly compliant to medications. Upon further interrogation in family history, there is noted sudden death of his brother, which is just about 30 years old. On physical examination, the patient is well-appearing, medium-built, gentleman. He has stable vital signs. The cardiopulmonary, abdomen, extremities, and neurologic examinations were all unremarkable. So these are the questions that we will be dealing for this topic. First, what is the approach to syncope? Second, what are the ECG markers of sudden death? How do you classify ventricular tachycardia or VT? What additional diagnostics will be recommended for such patients who needs specialty care or specialty cardiovascular or electrophysiologic care? And how to manage these patients, including how to continue the care by primary physicians. So without further ado, here is Dr. Giselle Herbacio.
Hello, everyone. First, thank you to the organizing committee for this opportunity to interact with our physicians from all around the region and all around the country. We hope that everyone is doing well. Also, thank you, Dr. Ray Matias, for introducing the topic very adequately. So when we say syncope, it means a transient loss of consciousness. This is different from sudden death. In sudden death, of course, there is already ventricular fibrillation or cardiac arrest. Although the two topics may be intertwined because syncope may be like a warning or a trigger for sudden cardiac death. And that is actually the challenge. How do we identify the patients who are presenting already with blackouts who are at high risk for sudden cardiac death? Okay, so we start with a total loss of consciousness. And then, of course, we have to eliminate those with head trauma because that is totally a different category. We will focus instead on syncope. And there are three general categories of syncope. The most benign is, of course, reflex syncope, vasovagal syncope. But among the elderly, there's the orthostatic hypotension that is common because of either autonomic dysfunction or a lot of them have medications that may lower the blood pressure. And then the highest risk is, of course, cardiac syncope because it may be linked with structural heart disease or with inborn channelopathies or electrical problems. Now, for this particular case, for example, the triggers are that, well, number one, it happened while the patient was driving. So that's one warning clue that that's not the ordinary vasovagal syncope. Second, he met a vehicular accident, which sort of tells us that he had no warning. He had no time to pull the car over and protect himself, resulting in a vehicular accident. And then the third trigger is that there is a family history of sudden cardiac death. So those are the red flags that suggest to us that this may not just be the benign form of syncope. But highlighted here in this orange box are the other possible triggers. So we mentioned if it happens during exertion, if there's a family history, if there's underlying structural heart problems. And for this, you will need, of course, your physical exam and sometimes the need for some ancillary tests like a 2D echocardiogram and obviously the electrocardiogram. Okay, so this slide is a little busy, but I want to highlight several things. First is that in the initial evaluation of syncope, everyone must have a complete history, and that includes the list of drugs or medications that the patient is on. Some people tend to gloss over the past history. Very important family history. We already mentioned that earlier. And then if the patient has other coronary risk factors, those should be included. Physical exam must be complete. And the electrocardiogram is already part of the basic test that needs to be done because it is widely available and very affordable. And we have some slides later to show that a wealth of information may be gathered just from the electrocardiogram. Now, the other thing I would like to highlight is that there are three different categories of findings when you take this algorithm. One is the patient where from the history and PE, the initial evaluation will already yield you a diagnosis. And in such a case, it is said that no additional workup may be needed. For example, it is classically vasovagal, then it does not make sense, nor does it serve the patient right to do a shotgun of testing because it might lead to a diagnostic trap and more testing, more false positives, and so forth down the line. Now, the second category is those with an obvious cause. For example, the initial evaluation shows that it is clearly a coronary cause. Patient has chest pain or patient has frank heart failure. Then you have to do targeted testing. You have to already focus, for example, on doing stress testing to rule out coronary artery disease, or for example, the syncope appears to be from let's say it's from a neurologic cause. What would tell you it's neurologic? If it's prolonged, very prolonged, like more than just a few minutes. If there is post-ictal confusion, so the patient is not back to normal when he regains consciousness, he's groggy or drowsy, that would suggest, or if there's headache, if there's severely elevated blood pressure, if there are neurologic deficits, those are the things where there is clearly a directed testing that is required. And then the third category are those with unclear diagnosis. So even after you have done your initial history, PE, ECG, you're still in the gray or in the gray area. You're not yet sure. So some of the considerations are, for example, if it's a young patient and the syncope is not high risk, meaning no injury, the patient did not injure himself, then you might think more of vasovagal. On the other hand, if the patient is elderly, you might think more of an arrhythmia, especially if the patient hurts himself. So those are the fine pieces of information that might help you streamline so that you don't end up with a shotgun approach to syncope. Okay, so this is an additional piece of information. And at this point, I will ask Jerome to walk everyone through this ECG. So this is the ECG of the patient he presented earlier. Take it away, Jerome.
Yes, thank you, Ma'am Giselle. So when reading an ECG, so this is a 12-lead ECG. First, you should identify first if this is the ECG of the patient, patient ID. Second, you should check for the standardization of the ECG. All right. For this ECG, we should identify first the rhythm of the patient. And for looking into the limb blades, 2, 3, and AVF, you can see a very prominent P wave. Hope you can see. So every P wave is preceding a QRS. All right. So we shall call this sinus rhythm. And the rate of the ECG is about 102 beats per minute. So this is sinus tachycardia. Looking in leads 1 in AVL, you can tell that the axis is normal. There is also no hypertrophy. Looking at the ECG pattern, there is an atypical RBB pattern when looking carefully at lead V1 and V6. However, I would like to bring your attention to lead V1 and V2. As you can see, there is a prominent cove ST elevation greater than 2 millimeter, and there is also a T-wave inversion. So this pattern is typical of Brugada type 1 pattern.
Okay, so I would also like to add that this was a 52-year-old male. So when you have a 52-year-old male, you would also want to entertain other differential diagnosis. In particular, you want to rule out coronary artery disease. So if this ECG were found in a young male with no other comorbidities, you would go right away and suspect Brugada syndrome. But since this is middle-aged male with risk factors, then one of the differentials is, of course, coronary artery disease. And it warrants that this be ruled out before you label the patient as having just Brugada syndrome. The other piece of information is that the syncope happened while the patient was driving. And the usual presentation of bangungot is, obviously from the term itself, is it happens during sleep. Okay, so now let's proceed to exploring more of other ECG markers, aside from the bangungot ECG pattern or the Brugada ECG pattern, that might alert one to the presence of sudden cardiac death. Okay, so this slide divides the ECG patterns into depolarization, which means that the abnormalities involve the QRS complexes, and repolarization, where the abnormalities involve the ST P wave segment of the ECG. So what are these? For depolarization abnormalities, you can have fragmentation of the QRS, Q waves, lengthy or prolonged QRS duration, fascicular and bundle branch blocks, low voltage QRS complexes, left ventricular hypertrophy, epsilon wave, and as shown earlier, the Brugada ECG pattern. Under repolarization abnormalities, you have the so-called early repolarization pattern, which basically looked like the Brugada pattern, but involving other leads. And then you can have T-wave alternance or QT dispersion. And importantly, also never forget the QT interval, because the QT interval may be prolonged or lengthened, either in response to some factors such as low potassium or low magnesium, but there is also a congenital form of long QT syndrome, which is another marker for sudden cardiac death. Okay, we mentioned bundle branch blocks. Actually, these are quite commonly encountered, and I will request Jerome again to describe the next two slides.
I agree, Ma'am Giselle. These are one of the most common patterns, ECG patterns somewhat we often see in the clinics when they're doing ECG. The first pattern is this one. This is the right bundle branch block pattern. The pattern can be recognized by looking into the QRS, which is broad. Okay, you can look also at leads V1, and you can see an RSR pattern. Yeah, okay. So looking at V6, there's a slurred S wave that you can see there. Okay, there. So this pattern, including the inverted T waves that you can see in V1 and V2, you can say that this is a right bundle branch block pattern. The second one is also a broad QRS complex. You can see a broad QRS. Okay, and as you can see in V1, V2, V3, there seems to be some delay in the progression of R wave. Right? Okay, and looking at V5 and V6, the peak to R wave is somewhat slurred. And there's somewhat of bunny ears in the V5 and V6. Okay, in addition, compared to the T wave inversion that you can see in V1 and V2 in right bundle branch block pattern, the T wave inversion or depression in left bundle branch block is in V5 and V6 on the lateral leads.
Okay, thank you very much, Jerome. So I will add that left bundle branch block is commonly a marker of structural heart disease. You can find it in coronary artery disease. You can find it among heart failure patients. You can find it among patients who have conduction system problems. On the other hand, right bundle branch block has a more diverse setting. So majority of right bundle branch block is benign. So you will sometimes get patients in your clinic where they are young, asymptomatic, and they have right bundle branch block. They may be observed. On the other hand, some patients with, as Jerome mentioned earlier, Brugada ECG pattern may initially present with what looks like right bundle branch block. And then when you give these patients a drug like flecainide or adjmalin, lo and behold, you may unmask the so-called Brugada ECG pattern. So that is the significance of having these bundle branch blocks. But other than the bundle branch blocks, we mentioned earlier, if you have Q waves are markers of scar in the heart. If you look at the principle of vectors, you will develop a Q wave if that particular wall is electrically not contracting or there's a scar. And by the principle of vector, you will register a signal that is going away, hence a negative signal, hence the Q waves. And then we also have delta waves. Delta waves are what look like slurring at the start of the QRS, and they are a marker of what we call pre-excitation. The clinical diagnosis is usually WPW, Wolff-Parkinson-White syndrome, and this is an inborn pathway found in a small percentage of the population. The significance of which is this inborn pathway is capable of conducting very rapidly, and it may bypass the normal AV conduction system, resulting in very fast tachyarrhythmias that may predispose the patient to sudden cardiac death. Now, epsilon waves here, as pointed by the arrow, they look like P waves at the end of the QRS. They're like small bumps at the end of the QRS. And one will perhaps intuitively guess that the end of the QRS represents the last part of the ventricular activation, which is the right ventricle, because the normal sequence of activation is left ventricle followed by right ventricle. Now, when there is some scarring in the right ventricle, it may register as an epsilon wave, which is one of the markers of RV cardiomyopathy or arrhythmogenic RV dysplasia. And the epsilon wave is one of the major criteria for a rare condition called arrhythmogenic RV cardiomyopathy, said to be one of the differential diagnoses for bangungot. In earlier studies, they found that some, not a big portion, but a small minority of bangungot patients have this arrhythmogenic RV cardiomyopathy. And then we also mentioned QT prolongation, whether it be acquired due to electrolytes or other factors, or inborn congenital, is another marker of sudden cardiac death. Okay, now, when we say ventricular arrhythmias, it means you have an abnormality in the rhythm involving one or both ventricles. And there are several patterns. The most common is, of course, the PVC. The PVC is just like a burp in the normal rhythm, because it interrupts, like a hiccup, the normal rhythm with single wide, bizarre looking QRSs, whether it be isolated or bigeminal. Every other beat is PVC, trigeminal, couplet. This is already VT. When you have 3 or more consecutive PVCs, that's VT. And we call it sustained VT if it lasts 30 seconds or more. This is polymorphic VT because, unlike the example above, it has varying QRS morphologies. And if you have polymorphic VT with a long QT interval, then that is torsade type 1, which is one of the dangerous arrhythmias that may lead to sudden cardiac death. And then you can also have ventricular fibrillation, where everything is disorganized and there is no effective heart contraction. Now, we mentioned earlier that VT can happen either in the setting of structural heart disease or in the setting of a normal heart. One can guess that if you have structural heart disease, that's the most dangerous type of VT. So we have 2 pictures here. So this picture on the left shows a normal heart, and then you have a focus of VT. So the focus is that big lavender circle or oval that is firing regularly, resulting in this wide QRS tachycardia. This is usually not dangerous because if the heart is structurally normal, then it can tolerate fast rhythms. The other reason it is not dangerous is because it is focal, only 1 or 2 spots. You can actually cauterize this spot and you will get rid of the arrhythmia. In contradistinction, if you have structural heart disease, and we mentioned earlier that one of the most common structural heart diseases, if you have a scar in the heart, then you have a different mechanism of arrhythmia. It's re-entry, where you have recirculation of the impulses around and within the scar. The problem with scars is that they will be there forever. Hence, no matter how long after a myocardial infarction, the patient will always be at risk for sudden cardiac death. And the biggest predictor for sudden cardiac death is the ejection fraction on the 2D echo. The cutoff used in large clinical trials is 35%. So if you have an ejection fraction of less than 35%, then the first thing you should do is try to see whether you can improve it, whether by sending the patient for checking the coronary arteries and doing an angioplasty or a bypass, or giving medicines like Entresto. Ultimately, after treatment, if your ejection fraction remains low, then you are at high risk for sudden cardiac death. And the mechanism for that is ventricular tachycardia. Now, there's this subset of patients that have structurally normal hearts, but they might have an inborn problem with the ion channels. So whether it be the sodium ion channel, the potassium ion channel, the calcium ion channel, there might be a genetic problem leading to over or under function and leading to specific syndromes such as long QT syndrome, short QT syndrome, early repolarization syndrome, and Brugada syndrome. Brugada syndrome is like the Western counterpart of bangungot. The ECG that Jerome described earlier is a prototype for Brugada syndrome ECG. So early repolarization syndrome is like the umbrella diagnosis for Brugada syndrome. And a lot of people believe that this is like the explanation for bangungot, although there is ongoing work to really confirm that, because like I mentioned earlier, bangungot might actually be a conglomeration of several diagnoses, the majority of which is Brugada syndrome, but some of them might have RV cardiomyopathy. Okay, so what is the treatment for channelopathies? It depends. For long QT syndrome, it's usually a beta blocker. For Brugada syndrome, it's usually a defibrillator, an implantable defibrillator. I'll show a picture later. So there is a final subset of VT called idiopathic VT, which a lot of people don't know too much about. And for this, I will refer you to, there's a Philippine College of Physicians IM textbook that was just released earlier this year that describes idiopathic VT. Idiopathic VT means we don't know the cause. That's what idiopathic means. But there is no structural heart disease. And as such, it's benign. It's not the type where you will expect the patient to just drop dead. And it's focal, like the example I showed earlier. And since it's focal, it's amenable to catheter ablation. There are two main types. There's the outflow tract, VT. When we say outflow tract, that's the outflow tract of either the right ventricle or the left ventricle. And there's the fascicular VT, which involves the left anterior or posterior fascicles. Those are the two branches of the left bundle branch. So I didn't put ECGs anymore for these two because you might be overwhelmed. But suffice it to say that they are both benign and amenable to catheter ablation. Okay, so now let's go to the diagnostic approach to VT and sudden cardiac death. Okay, so I will move this to get it out of the way. And here, there are actually three tiers. This is as proposed in this arrhythmia and EP review published recently. So in a patient who has suffered sudden cardiac death, obviously one must be very aggressive because they have suffered the worst already. This is your second chance to intervene. Hopefully, the neurologic deficit is not grave, but in majority of cases, it may be because it takes a while to be able to bring the patient to the emergency room. So we mentioned, like in syncope, history cannot be overemphasized. And then physical examination, you have to do blood work to check for metabolic causes. ECG, we discussed that earlier. What are the markers? Echocardiogram, fortunately, is available in most places in the country, at least in the bigger cities and towns, that will tell us whether there is structural heart disease or not. And then coronary assessment. Here, this I think is already becoming more and more available. But this is not necessarily coronary angiogram. It may also include stress testing, stress imaging. There is also the CT coronary angiogram. And then, of course, now, fortunately, the coronary angiogram is now accessed to the wrist, so it's less disabling for the patient. And then the second tier is if the above first tier tests yield negative results, cardiac magnetic resonance imaging is already the gold standard for defining structural heart abnormalities. It's especially good for defining the right ventricle, which is not very visible on 2D echo, and also for defining myocarditis, for defining the extent of the scar. So I think in the future, this will play an even bigger role as far as the approach to patients with syncope and sudden cardiac death. Provocation testing includes stress testing, and then epinephrine infusion may be used to unmask QT prolongation, which sometimes is concealed. And then sodium channel provocation test is used to unmask Brugada ECG pattern because the pattern of Brugada is waxing and waning. And for example, you have a patient who has blackout and the ECG pattern is not yet quite the full blast ECG pattern as Jerome showed earlier. You can load a sodium channel blockade. Of course, this is done in the EP lab under very controlled circumstances to unmask the Brugada ECG pattern and clinch the diagnosis of Brugada syndrome. Now, the third tier is, of course, even more specialized. You can try to provoke vasospasm. You can do an electrophysiologic study, which is like a coronary angiogram, but to check the electrical system of the heart. And then genetic testing. Genetic testing is already class 1 indication in the management for long QT syndrome because it will tell you whether the patient is beta blocker sensitive or not. And that makes a world of a difference as far as managing long QT syndrome. Okay, now, sorry. Okay, now the next question is who needs or who will benefit from specialty consultation? So I made here a list. High-risk syncope, which are the elderly patients, those who have body injuries because of the syncope, those with the high-risk ECG features just enumerated, and those with structural heart disease. Of course, those with palpitations, and that includes the elderly, same subset of patients, but the difference between the two is the first presented with syncope, the second presented with palpitations. If there's a family history of sudden death, as in the patient presented in the heart failure patients. Okay, how do we treat them? This is an algorithm from Douglas Zipes. I think what needs to be highlighted here is if, of course, you treat all the reversible causes, you treat all the specific causes. So if there's a blockage that needs to be fixed, you fix that. Of course, you load all the guideline-directed medical therapies. So a lot of people are already aware of the class 1 medications like Entresto for heart failure, beta blocker to prevent sudden cardiac death. And then after having done and corrected those, you continue to ask, is there anything reversible that may still be corrected? Ischemia, long QT from electrolytes, drugs. There are a lot of drugs that can prolong the QT. But if there is nothing more to correct, then I guess the next question to ask is there underlying structural heart disease? Because if there is none, then that's idiopathic VT, then that will not require an ICD. The people that will require an ICD are those with structural heart disease. And as an adjunct, if they continue to have ICD discharges, then you can add drug on top of the ICD or even ablation. Ablation is a procedure where we sort of zap or burn the part of the circuit that is causing the ventricular arrhythmia. Now, I have, for the next 3 slides, I have sort of divided the 3 modalities for treating ventricular arrhythmias. So, of course, in the past, it all used to be antiarrhythmic drugs. And this is from a Cochrane review that showed the odds ratio in terms of efficacy, pro-arrhythmia, adverse effects, and death for some of the major antiarrhythmic drugs. Of course, the most popular in the Philippines are amiodarone and beta blocker. Amiodarone is, of course, quite potent, the most potent antiarrhythmic drug. So you will see here that you have the lowest odds ratio or hazard ratio for amiodarone. The others are milder compared to amiodarone. For pro-arrhythmia, the most pro-arrhythmic is flecainide and the other sodium channel blockers and sotalol. But in spite of amiodarone being very effective, it has the most adverse effects, extracardiac adverse effects. And a lot of these adverse effects develop years down the road after starting it, the most common of which are hypo and hyperthyroidism. But you can also have serious adverse effects like pulmonary fibrosis. And then metoprolol, the adverse effect of metoprolol is more bradycardia and hypotension. Now, in terms of death, the highest would be for sotalol. Metoprolol may sometimes, well, I don't know why this is, because of all the antiarrhythmic drugs, metoprolol is, beta blockers are the only class of drugs that prolong survival. So I don't know why this has an odds ratio of 2. Okay, let's go to the next. We mentioned catheter ablation. Catheter ablation uses a catheter to deliver energy either to the focus of the arrhythmia or to a vulnerable part of the circuit to terminate the circuit. And the main application for this is for idiopathic VT or for scar-related VT, where you have incessant shocks coming from the implantable cardioverter defibrillator. And this is the implantable cardioverter defibrillator. It looks like a big pacemaker implanted under the skin, and it's connected to 1, 2, or 3 leads that are threaded through the axillary vein into the heart. So the defibrillator lead is in the right ventricle. There's a shock coil there that allows the generator to deliver a high voltage shock to convert ventricular arrhythmias with the shock here. So the VT here is converted back to sinus rhythm. And the highest yield for the ICD is in scar-related VT. Here, these are nuclear images. You will see that part of the heart wall is no longer perfused, indicating a scar. So if your scar is big enough to yield an ejection fraction of less than 35%, then that's the class 1 indication to get a defibrillator. Okay, now, how do we bring all this knowledge to the primary care physician, which is you guys? The primary care physician is the team captain. You assemble the team. We as specialists do our part in terms of managing the specific problem sent to us, but you're the team captain. Never forget that. Hence, you need to maintain regular follow-up with the patient and family. Of course, after the specialist resolves the problem, then he gives the patient back to the primary care physician. And some of the things that may help are, of course, controlling the heart rate, because in a lot of conditions like coronary artery disease and heart failure, heart rate drives outcome. As much as possible, maintain a normal rhythm. And then treat the underlying disease or condition that may be causing the arrhythmia. Treat the risk factors. What are the warning symptoms that the patient needs to go to the ER or needs closer follow-up? Palpitations, pre-syncope, syncope, heart and heart failure symptoms. And then always keep an open line with the whole team. Now, more and more family conference and multidisciplinary meetings are very valuable as far as keeping a coherent management for the patient. Okay, now as a last segment of this lecture, I'd like to highlight that we are fortunate to have gotten government funding from the PCHRD for the Philippine Bangungot program. And in this program, there are two projects, the Bangungot project and the Brigada project, which aim to enroll patients in trios. One trio is the proband and both parents. The Bangungot trios are enrolled usually from the Philippine National Police, because obviously these are dead. Most of them are dead subjects, and they have been sent to the PNP for autopsies. The autopsies do not reveal pancreatitis because we have ruled that out already as the cause of bangungot. Instead, most of them reveal normal autopsies or some RV cardiomyopathy, and then we also include both parents. For the Brugada project, diagnosed Brugada syndrome patients and referrals are welcome from around the country. The trios enrolled from both projects will undergo next generation sequencing or whole exome sequencing to discover novel variants causing the two above conditions. And the variants identified will undergo expert panel and literature review adjudication and a statistic called the transmission disequilibrium test, which will tell us whether the variant is a significant variant or not. Then there's a phase 2 for targeted testing involving the already identified genes, and that will include 60 bangungot and 80 brugada compared with similar number of age and gender matched controls. So we're excited to be able to launch this, and this is the graphical abstract showing the showing the objectives, both general and specific objectives. Basically, we want to determine the pattern of inheritance, the specific genetic mutations, to adjudicate the pathogenicity, to compare demographic and clinical criteria, and so forth down the line. And this is the methodology. This is again another reminder of what the Brugada ECG pattern looks like, as described by Jerome earlier. So you have the J point and convex or cove type of ST elevation, at least 2 millimeters in leads V1 and V2 with a T-wave inversion. And blood is the sample taken, sometimes tissue from cadavers. And this undergoes genetic testing and adjudication. There will be pre and post-test genetic counseling offered to the patients. So I think this is my last slide. I would like to, again, end on a note of managing our patients with ventricular arrhythmias is a shared responsibility. Of course, among the different members of the team approach is usually the most effective. On the ground, you guys are the people on the ground. It is highly essential to know what to look for. I've mentioned several times that history, physical exam, and ECG are widely available for almost all patients, so this should be maximized. But learning what the high-risk ECG markers are and learning how to approach both syncope and sudden cardiac death is really the best way to identify who needs a specialty referral so that we can work together. So on this note, I would like to turn back the floor to Jerome. Thank you, everyone.
Yan. Hello, thank you so much, Dr. Giselle Herbacio, for a very enlightening session, a very electrifying session. I hope you understand those things these things that can help our patients, for us as well, to further the cardiovascular care of our patients. So if you have questions, you may type it in. or you may do it live and we will answer it in a while. Thank you so much.